Our today next speaker is Dr. Raza Sayyed, who is a renowned surgical oncologist currently working as Patel Hospital with a special interest in colorectal cancer, peritoneal malignancies, and soft tissue sarcomas.
Assalamu alaikum. Thank you very much for this opportunity. So the topic that I selected was how radical should we be for surgery for colon cancer. It was initially meant to be a talk centering around CME, but then I thought I found out that someone had already stolen that topic and is speaking before me. But many thanks that Dr. Irfan has covered most of the basics for what I'm going to go through. I hope this is working. So, Bismillah ar-Rahman ar-Rahim. Fadabarakallahu ahsanul khaliqeen. So blessed is Allah, the best of creators. And God has created many things in packages. This shiny fruit of labor wrapped in this shiny package up to its core, containing seeds. It just reminds us of how many things that we in our surgical oncology career see as packages. And it does go down to how we look at the evolution of rectal cancer surgery. And Dr. Irfan talked about how the improvement in the outcomes came along with an improvement in technique. We do think of the whole context of this ayah that I recited, that how Allah developed a drop of semen into a congealed clot, and from that into a lump, from that into bone, and then flesh over that bone to make a new creation. And that makes us think about the embryology of how this convoluted current day anatomy of the small and large bowel comes into play. And when we look at it in real life, we look at how one single root gives rise to the whole package of mesentery for the small bowel, separate from the mesentery for the right colon and the transverse colon. And it's all this seemingly familiar anatomy and this complicated, convoluted embryology that we try and undo in our pursuit of excellence in obtaining outcomes for colon cancer. And this is what we basically look at. As we know that the preamble has been built that improvements in rectal cancer surgery led to an improved outcome, and that surpassed the outcomes for colon cancer, and there was a need for standardization for colonic resections. Hornberger actually demonstrated that performing a certain technique over a number of years improves outcomes, and he demonstrated an improvement in the outcome for colon cancer. The only thing is that the duration of this study was from 1978 to 2002, and there were many things that changed during that time. No doubt that this technique is really superior, and it takes out the embryological package along with the central vessels. But there were remarkable evolution in the systemic therapy for colon cancer at that time as well. So there are multiple contributors. Just like outcomes for rectal cancer, it was TME plus additional things, better imaging, better local treatment in addition to surgery that resulted in improved outcomes for advanced cancers. Similarly, for colon cancer, we have not just the technique, but other factors into play as well. Nick West and his group, in addition, following this lead from rectal cancer surgery and the pathological grading for mesorectal specimens, they actually looked at the definition or grading for mesocolon from the MRC Classic study. And we see that there are, oh, this doesn't work. But anyway, the top right of the screen is a muscularis propria plane excision, in which the muscularis propria or the bowel wall is actually breached. And then the next specimen is an intramesocolic plane. So the bowel is intact, but there is a breach in the mesocolon that we talked about. And then the second one is a mesocolic plane, but not going up to the vessels of origin. And the bottom right one is a complete mesocolic excision. And they basically looked at a number of cases in their own institution and showed that the top curve, the top survival curve in each of these figures is the mesocolic plane excision, and the bottom curve is the muscularis propria excision. And they showed that the outcomes are clearly better if the surgery is kept in the mesocolic plane. So taking lead from that, the Denmark basically included all their centers that were performing. They got trained and started performing complete mesocolic excision, and they compared the Danish National Colorectal Database for patients who underwent CME compared to conventional colon surgery. And they found that the patients who underwent CME did better, all comers as well as stage 1, stage 2. The curves seem to merge towards stage 3, but there is still an improved survival that they showed. So it's all about specimen-oriented surgery that we talked about. And this whole thing, the concept is morphometry. The whole specimen is looked at. How much bowel is taken out? Proximal margin, distal margin. We all think about that, and we talk about that a lot. But it's not just the only thing. The whole area of the mesentery or mesocolon is important. The distance from the tumor to the hyati, the distance from the closest distance of bowel to the hyati, they're all taken into account to have a look at the quality of the specimen himself. And that's what actually makes this the embryological package, just like a TME package that we try and follow. So the bottom blue plane is the visceral fascia, and then the mesocolic fascia, and this dotted line in between is the way that we have to go through to separate the mesocolon from the retroperitoneal fascia. And if this plane is breached, like Professor Chima said, that there may be deposits that can spill over, lymphatic spillover. The spread may not be regional, it may be a peritoneal spread, but we don't know how this spread happened, and we're thinking, oh, it's just bad disease. It may be a combination of factors, and our technical performance of the surgery may have to be one of the contributing factors. So Japanese have been looking at it, like Professor Saab said, for a long time. This was a more recent study where a single Japanese center looked at the distribution of lymph node metastasis within colon cancer. And then they just divided the pericolic or epicolic nodes and the intermediate nodes and the central nodes or the main lymph nodes. And then they looked at the distance from the tumor, the oral side and aboral side, from up to 5 centimeters, 5 to 10 centimeters, and beyond centimeters. We do see that for all comers, about 2% have central lymph node metastasis. About almost 10% have intermediate node metastasis. And majority of the other cancers that had lymph node metastases were in the pericolic or epicolic nodes. One thing that they found was distally, beyond 10 centimeters from the tumor, there were no nodes involved. And proximally, there were only 0.2% of the lymph nodes that were involved beyond 10 centimeters from the specimen. And that's why the Japanese classification and their guidelines recommend only a 10 centimeter margins, and the convention or the European or Western CME specimens usually have a larger specimen than that. And this, we could see that the central lymph nodes involvement in T1 cancers is 0, up to almost 15% in T2 cancer. So intermediate 15 and up to 4% in T4 cancers, central node involvement. And this distribution has been shown. It's more or less simple. 0 for cecum, the middle digit, 0 for cecum, 1 for right colon, 2 for transverse colon, 3 for descending, and 4 for sigmoid. And the third digit, 1 for epicolic or pericolic nodes, 2 for the intermediate nodes, and 3 for the central lymph nodes. And the package itself is defined by the location of the tumor and the vessel that feeds into it. The Japanese guidelines actually recommend a D3 dissection for all T3, T4 tumors or node-positive tumors, which are picked up on our preoperative imaging. The concept of nodal tears is important. I'll go back to this thing that if we say that only 4% or 1% or 2% are involved and taking them may not make a difference, it's actually, we have to look at the perspective that they look at, is that if the intermediate nodes are involved, then we have to go one tier above in our surgery to actually clear that regional disease. And that's the concept that they had applied in gastric cancer and had shown superior outcome. And this is what we're seeing them apply in colon cancer as well. And the other thing that Japanese guidelines and classification differ is that they define the extent of resection according to the feeding vessel. So up to 10 centimeter from the tumor, they would take on either side of the feeding artery 10 centimeters. If there is no feeding vessel within 10 centimeter from the tumor, they would still go 10 centimeter on one side of the tumor and 5 centimeters to the other side of the next feeding vessel. And then if there are 2 dominant arteries, then 5 centimeter to each side of the arteries. And if there are no feeding arteries, then the feeding artery or the artery closest to the tumor is taken as the vessel. It doesn't matter more or less towards the longitudinal extent, but it does define which vessel we're going to target if we're going to go for central nodal dissection. This is what I would want to dwell on, and it'll probably answer Professor Qureshi's question as well. This is the consensus statement on CME. The first reason that this all started was the colon cancer surgery wasn't standardized. Even CME itself is not standardized, and there are multiple different versions of it. And they came up, this group, the CME project working group, came up with a set of 23 recommendations answering each question. So with consensus, central vessel ligation is part of the CME dissection. For right colon cancer and transverse colon cancer, the right colic vessel, which feeds into the loop of the gastrocolic trunk of Henle, has to be taken. There is no consensus that could be reached about the right gastroepiploic vessel. So as far as the CME consensus statement is concerned, it's not sure whether you should or shouldn't. It may become a personal preference whether we should do it or not. We'll just touch on some of the outcomes, because these are prospective trials that are running and have produced their short-term outcomes. The RELARC from China has shown an equivalent complication in grade 3-4 clavin endomorbidity. There were no mortalities, but a higher incidence of vascular injury in CME dissection. Only 3% of sentinel nodes were positive, and there were no cases of isolated sentinel node positivity. In the COLE trial from Russia, the short outcomes again did not show any difference between the short-term outcomes or morbidity. There were no mortality and 5% sentinel node positivity. We know that oncological outcomes, my review of literature actually missed out the study from Benz, but we have data from retrospective studies that the 5-year outcome overall survival ranges somewhere around 90%. We know from studies that have looked at this that the sentinel nodes, if they're positive, they confer a poorer survival. And for those patients who have sentinel nodal involvement, if it's N1 involvement, then following a CME-CVL, they have been shown to have a 71% recurrence-free survival, which is quite good. So there is a debate, and this will probably be answered by the outcomes that we see from the RELAC and the COLE trial, and hopefully will answer this question. To summarize, we know that surgery in embryological planes has shown to improve survival. We're still debating about the extent of lymphadenectomy, and it has to be case selection. The morbidity and mortality of these techniques have been shown to be acceptable in trained hands. And so gaining expertise and getting trained and setting up a training framework is very important. Standardized surgery will lead to improved outcomes, and the specimen itself can tell you how the surgery went. I would also like to share the Surgical Oncology Society conference, which will be in February this year, and we welcome you all to come and attend. Thank you very much. Questions at the end? Yes, if you're dissecting close to vessels, the incidence of injuries will be increased. But I think what we need to look at is that there were no mortalities. And when we look at the incidence of grade 3, 4 morbidity, this was equivalent in both groups. So yes, the incidence of injuries is high, but they were all managed because they were being performed by trained surgeons.
Yes. With permission? Sorry. No. There is nobody above immunity. You mentioned the nodal status, which is a real crux. How do we preoperatively assess the nodal involvement on the current modalities? And the best published series with CT scan imaging, although they did it with MR as well, and then didn't improve the figure, it's about 65%. And I think this is where the problem really lies, because how accurately you could predict preoperatively to go after those nodes. And they may be an overkill, and as we know, sometimes they look bigger and wider and you go after them, 4 hours of surgery, they all come back as N0, or they may be undercall as well. So I think there is a lot of work now in Europe, certainly. They're looking into radionomic signatures, trying to improve the preoperative imaging. Because as you know from Foxtrot trial data, we were contributing in Foxtrot from Portsmouth. और जनरली जो CT पे वो कहता था नोड्स हैं वो चले जाते थे कीमो के लिए, बाद में पता चलता कि नोड इसमें है ही नहीं थे, इसको कीमो की ज़रूरत ही नहीं थी. So I think you hit it spot on. जो मैसेज आपकी टॉक से जो मुझे मिला है, या जनरली मेरा ख्याल है जो बाकी लोगों को मिलना चाहिए, कि जो मीजोकॉलिक प्लेन की सर्जरी है ना, दैट इज़ व्हाट इज़ गोइंग टू इम्प्रूव आउटकम फॉर up to 90+% of our clonic tumors. जो आप बात कर रहे हैं ना 3 to 5% of central nodes, वो उन patients के लिए definitely ज़रूर है, और वो 3 or 5% अगर मैं और आप हों तो हम चाहेंगे कि हमारी CME हो. लेकिन ये है कि ये important है कि CME का concept लोग समझ लें और इसको भी इतनी respect दें जितनी rectal cancer को देते हैं.
Exactly. Thank you, sir.
Thank you, Dr. Raza.